Colonoscopic full-thickness resection as a prelude to endoluminal colon surgery. Complete resection of colon polyps is critical to avoid recurrence of colon polyps. The technique of endoscopic resection depends on the type of the lesion. Snare resection for pedunculated polyps, either snare resection or endoscopic mucosal resection for sessile polyps, endoscopic mucosal resection for flat lesions, and endoscopic submucosal dissection for lateral spreading lesions. Both endoscopic mucosal resection and endoscopic submucosal dissection are technically more challenging than simple snare resection of colon polyps. Although one should select the most appropriate resection technique depending on the type of the lesion, in practice, snare resection is often used for management of pedunculated polyps as well as sessile polyps and even flat lesions and lateral spreading lesions. This can result in recurrence of polyps, especially after the use of simple snare resection for removing sessile polyps, flat lesions, and lateral spreading lesions. Surgery may be required in the management of these recurrent polyps as they tend to get tethered to the wall from scar tissue. Is there a way out of this problem? Could endoscopy be used to address this issue? Could endoluminal surgery be used as a novel concept in the management of recurrent polyps? This involves endoscopic full-thickness resection of the colon and removal of the lesion, followed by suture closure of the defect using through the endoscope devices. Successful tissue approximation and tissue resection are critical components of endoluminal surgery. Over the last 4 years, we have undertaken a series of animal experiments, pilot studies, a placebo-controlled trial, and a randomized control trial comparing endoscopy with surgery and demonstrated that endoscopic closure of colon perforations can be achieved. Colonoscopic full-thickness resection. Steps consist of a needle knife is used to mark the area with cautery. After marking, a full-thickness puncture is made and an IT knife was used to cut the marked area from 12 o'clock to 6 o'clock. Because of colon collapse, the remaining segment was cut using a lift and cut technique with a snare and a grasping forceps. Subsequently, suture closure was attempted, and the steps include the following. First, the top edge of the perforation was punctured with a needle and a T-tag was delivered. Then, the bottom edge of the perforation was punctured and another T-tag was delivered. Then, a knot tying device was used to approximate the edges and complete suture closure. 10 animals were used for the experiment. A double-channel endoscope was used for this purpose. After cleaning the colon, needle knife cautery was used to mark a 2 cm circular area. After puncturing the colon at 12 o'clock with an IT knife, full-thickness cut was made from 12 o'clock to 6 o'clock in the anti-clockwise direction by gently pulling the endoscope down. Subsequently, using a grasping forceps and a snare, the remaining half of the circular area was resected using the lift and cut technique using pure coagulation set at 25 watts. Following the resection of the specimen, it was retrieved using a grasping forceps, and subsequently suture closure was undertaken. Suture closure was undertaken from the proximal to the distal side of the perforation. After gentle needle puncture of the top edge of the perforation, followed by insertion of the T-tag, a second T-tag was inserted at the lower end of the perforation, and both the sutures were closed with a knot tying element. Notice the smaller residual defect after the first closure. Then the third T-tag was inserted to the right of the first suture, followed by the fourth T-tag below, and subsequently a knot tying element was used to make the second suture. Notice the much smaller residual defect after 2 suture closures. Then the 5th T-tag was inserted, followed by the 6th T-tag, and finally a 3rd suture closure was made with complete closure of the circular defect. The animals were survived for 2 weeks. A necropsy was undertaken. As you can see, a clean peritoneal cavity, clean right and left paracolic gutters, and a leak test was performed using methylene blue injection, and there was no leakage of dye after injection of methylene blue even underwater. A fluoroscopy was used to check if there was any evidence of luminal stenosis following closure of the circular defect with endoluminal suturing. As you could see, there was no stenosis except for a slight bend at the site of the resection that was closed. Of the 10 colon full thickness resections, 9 were technically successful, 1 failed. Of the 9, 8 survived without evidence of peritonitis or adhesions. 1 animal had mild peritonitis from a small leak. In conclusion, colonoscopic full thickness resection is technically feasible and successful. It may have a role in the management of benign recurrent polyps as an alternative to surgery. Thank you.